So thanks to Polly, and this is Meryl Johnson, and actually we're going to go on now to some kind of less specific issues related to transplant, but how all of this actually interacts with what else is going on in our hospitals, at least for the first section of that. And I'll again tell about the speakers that'll go in this section. We'll start out with Atul Humar, who's the Director of Transplant ID at the University Health Network in Toronto, who will kind of give us some information about how their center is dealing with this currently and also has some previous experience during the SARS epidemic. I guess Luciano is listed again, I think primarily to mention a link to the JAMA video, which I think I listened to and people should find very helpful. Interview with an editor of JAMA with a colleague in Italy. Stacy Lorette, who is the chief at the Children's Hospital of Wisconsin down the road from me. We'll talk about managing patient and family concerns as well as medication supplies. And then finally, Lou Tepperman, who is in the thick of things in New York, will talk about how we can actually interact with and take care of our patients, perhaps in a way without seeing them. So without further ado, I'll pass it to Dr. Humar, and go ahead.
Thank you, Meryl, and thank you for the opportunity. Can you hear me?
Yes, we can.
Okay, great. So I'm going to talk about management of the transplant program in the setting of a pandemic. So next slide. So a lot of the considerations we've talked specifically about so far have been around transplant patients and how to navigate donor and recipient management. But a lot of the planning, I think, will be driven by factors external to the transplant program. So in the context of a pandemic, heavy resource utilization, use of ICU beds, ventilators, and ward beds, with most estimates being about 5 ward patients admitted for every ICU patient, means really scaling back transplant activity is inevitable. And also for donors, with limited ICU capacity, workup and identification of donors becomes more difficult as well. The other issue is high rates of healthcare worker absenteeism is a big problem. And then the final thing, which we've already talked about, I think, is immunosuppressing otherwise stable patients during a pandemic. So at our own institution, we've developed a phased approach to transplant volume reductions. And I think this is necessary to try to conserve resources, but also to minimize waitlist impact for our patients. Next slide. So this is a table, and this is just published today online actually as well. And it goes through different phases of reductions that transplant programs could consider, all the way from a 25% reduction to a 50% reduction to all the way to 100% reduction. So in a 25% reduction phase, I think this is when activity is just starting in your jurisdiction and you're doing the planning and you're expecting the wave of patients to come. And there you could think about, for kidney, for example, no live donor activity, but continued deceased donor activity. For liver transplant, no living donor activity for stable recipients, but allow it for more advanced recipients, and continued deceased donor activity. Continue heart and lung activity, but pause on some of the pancreas transplant alone and pancreas after kidney activity. Then in the next phase is a 50% reduction, which I think most places in the US and many places in Canada are at that stage, and certainly many places in Europe, I feel, are probably beyond that stage. This is where you might consider transplant only for semi-urgent or urgent cases, patients who really need the service. And so in that situation, you would pause kidney transplant activity, both deceased donor and living donor activity, except with the potential option of highly sensitized patients who are unlikely to get another offer. You may restrict liver transplant activity to only recipients who have MELDs above a certain category, and that's each jurisdiction has to decide that MELD cutoff. And similarly for heart, you may restrict activity to intermediate status or higher patients. For lung activity, you could allow all patients in that setting still to go forward, but defer for very stable patients. And for kidney pancreas activity, you would generally pause except for high PRA as above. So next slide. Then as you get to a more severe situation where you're seeing a lot of ICU capacity being used up due to COVID, you would go into a 75% reduction mode. And here, really, you would only be doing what are considered the very high need transplants. So liver transplant, kidney activity would be paused for the most part. Liver transplant would be for very high mild or fulminant hepatic failure. Heart transplant would be high status only, and the status classification differs by country and jurisdiction. And lung transplant would be reserved for rapidly deteriorating patients. And then the final category is, of course, 100% reduction in transplant activity. And there are places that unfortunately are in this situation. And here, there's really no ICU capacity available. There's severe shortages of health personnel, severe shortage of ventilators. And this unfortunately will likely lead to a halt of all living and deceased donor transplant activity. And then I think there should be similar phased reductions occurring in ambulatory activity, the 25%, 50%, 75%, with deferral of non-essential visits and a really aggressive shift to virtual platforms for care. And I think we're going to hear a little bit more about that later. So I will stop there, and thank you very much.
Thank you for the opportunity to highlight essential components of patient and family management. We all know and are certainly experiencing unprecedented demands on our time to care for patients and families. Next slide, please. And while the first thought that comes to mind is clinical care and how we're managing our patients in the hospital, it's equally important to consider how we're supporting patients and families while they're managing their transplant in the home environment. Specifically, the volume of calls that are coming through with questions and concerns to our transplant team is enormous. So knowledge of reliable transplant-specific resources is critical to disseminate accurate information to patients and families. UNOS is one such valuable resource, and you can see a picture of the UNOS webpage that has COVID-19 highlighted. And UNOS has latest updates that are highlighted in yellow and updated frequently, and they also have links to some of the major transplant society websites that you can see on the right-hand side under quick links. And when you click on these major society websites, they include American Journal of Transplantation, AST, AOPO. It goes directly to their COVID-19 section within their website, so it's easy to access this information. There are also links to Centers for Disease Control and Prevention. Specifically, there are multiple sections that you as a transplant team member can go to and reference that include what you need to know, how you can share with your transplant families how to prepare their own family, and then frequently asked questions sections for healthcare professionals. We know also that access to medications is essential for our patients and their overall health, and we want to consider providing options for medications specifically that patients may or may not already be utilizing. 90-day medication supply might be one strategy that you could implement as a transplant program. If you're currently utilizing 30-day supply, you can increase that, and also potentially medication delivery service if that happens to be available based on their pharmacy. Both of these options are addressing the possible inability for transplant patients to get to the pharmacy to pick up their medications. Also, as a team, we want to be as efficient as possible. With all of the education that we are providing to our inpatients and in telehealth ambulatory visits, as well as over the phone, it's important to be able to document our conversations thoroughly but efficiently. And one way to do that is to create a shortcut within your electronic medical record for the education that you provide. These shortcuts can be used for providers, nurses, and coordinators for them to document their time with patients and families. You can also consider strategies to communicate with families without communicating with them in person or over the telephone. And one such strategy is to provide letters or also documents through your electronic health record. There are two types of letters that I want to highlight here. There's specifically general letters providing information and education about COVID-19 for patients and their families, and then also letters for work, specifically for patients and or their caregivers to be excused from their work or be afforded the opportunity to work from home. There are templates that are available at NATCO, which is the Organization for Transplant Professionals, and you can see the link here that you can use. And what these letters do is really provide a framework. You can edit these at whatever to best suit your program. Additionally, there are two other organizations that I want to point to your attention. The American Nurses Association. There is a screenshot of one of the documents available through their organization on the upper right-hand side. They provide colorful handouts that can be provided as an adjunct to the letter that you send in the mail, or also can be sent via electronic medical record, the electronic health system. And some of the options that they have available to you are handouts titled What You Need to Know, What to Do If You're Sick, Guidelines to Prevent the Spread Within Your Home, and What are Symptoms of the Coronavirus Disease. Furthermore, the World Health Organization is another important resource to be familiar with. This has media resources that include press briefings, as well as videos specifically geared to the public on how to protect yourself during the COVID-19 outbreak. There's also these Mythbusters section, and you can see one of the pictures on the lower right-hand side. This one is specifically addressing the question, are antibiotics effective in preventing the new coronavirus? These are free and available for download and can be added into your letter that you provide to patients and families. These are all resources that can be used in written communication or can also be used to inform your conversations with families to help them feel informed during this challenging time. Thank you.
Hi, I'm Lou Teverman in New York, and as Lloyd had told you, it is true. There truly is we haven't hit a peak yet. There are over 20,000 individuals that have tested positive. We have 200 individuals in our hospitals right now, in our main two hospitals, with 60 individuals in our ICU, and we are repurposing our employees. If you can give me the next slide. I'm going to speak to you a little bit about telemedicine, which was turned into telehealth. Initially, telemedicine just referred to the physician, and telehealth refers to all the healthcare providers and all the support staff that we can use in education and of course, remote monitoring of our patients. Right now, for our outpatient clinics in New York, 90% of the visits have been, they're no longer an inpatient and in-person visit, and we're looking to telehealth to help us out. Telehealth initially was for care in the rural setting, and then it was supposed to be used by the military for forward deployment and difficult to reach settings. And now, of course, we're using it for COVID. And it has been underutilized in our country and for disasters. It can manage the surge of patients and handle closure of outpatient offices, which is now happening throughout New York. It allows clinical experts to respond without being there. This will be a test of our system. So telehealth, for our Italians, I'm sorry to say this, it's all about who has control. It's HIPAA, and I'll tell you the new caveats to this. HIPAA stands for Health Insurance Portability and Accountability Act, and there were real compliance changes in 2003, and that protected health information, and they were linked to payment. And this is why telehealth has not really surged until March 6th, when our government said they lifted geographic restrictions, and now private carriers and Medicaid, we were allowed to bill for point-to-point physician care. And then the Secretary expanded Medicare coverage for telehealth visits in March 17th. And there's a link to this in the documents associated with this webinar that you can read for FAQs. And so they waived potential HIPAA penalties for good faith efforts for telehealth, and they looked at cost sharing for beneficiaries and reduced and waived them. And so essentially this is a get out of jail card get out of jail for free. If you make a good faith effort and you record your events with telehealth, no one's going to come after you. So we have two main types that you can use. Virtual private network, that is trying to make a tunnel. So imagine that you're going through a mountainside tunnel and no one can see inside you. That is one very protected area, and that stands for a virtual private network. And instead of sharing the fiber traffic, it's totally protected. And you can notice these to know if you're on a protected network when it starts off with HTTPS, and that's a secure address. The other way is what we're used to now is end-to-end encryption. So, you know, your phone can work that way, and WhatsApp will work that way. So on one side it's encrypted, and the other side, the receiving end, it is unencrypted or decoded. So you can set up telehealth to one of your patients with one of the programs that you can use, and everyone's using different ones. It doesn't make a difference as long as they're protected. And send an SMS text, have your patient then press that, download the program, download the software, then make an appointment, connect to them, and then you can record this in the medical record and you're home free. Next slide, please. So what are we doing? There are many ways to do this. Just to let you know, we are employing AmWell, which is American Well, which uses the cloud for one of our concepts. And we're using the surge with these carts that you can see to treat COVID-19 patients. You don't want to necessarily get in all the rooms. The one on the right is an eICU. Our transplant ICU, which is the newest ICU in the Northwell system, is eICU. So there are cameras and monitors and microphones throughout the rooms, and the patients can see you, you can see them. That unit has been turned into a COVID unit. It's 18 beds. It's all full. It's an ICUs and ventilator. So we're now we don't allow family visitors to the hospital at present. And so these patients can communicate to their loved ones through this. They can see them. And then we're also having to communicate end-of-life issues when family members are not allowed in the hospital. So telemedicine will help us succeed, and will also help us in some of our darkest hours. I do believe that this is going to be a marathon, not a sprint. And I think this is an opportunity to use telehealth. Thank you very much.
So thank you, Lloyd. I think that there's a lot of information that's coming through here, and I think that, you know, unfortunately, in the interest of time, I've been said that I have one question to really ask people, and I guess I will go back and really ask Dr. Humar. You know, you actually had those 50, 25, 50, 75%, 100%. You know, where are you in Toronto now? And, you know, we can't predict the future, but you know, how can we prepare best in our own centers to deal with the issues that are coming forward?
So that's a good question. In Toronto, we're approximately at 50% or a little bit higher than that pause in activity. And the current state in Toronto is that there's a fair amount of community transmission going on. We're starting to see patients admitted and some in our ICUs. So we've paused all kidney activity with the exception of high PRA. We're continuing liver, both deceased and living donor liver activity, but prioritizing it to the higher MELD patients. For heart, we're doing higher status patients. Our lung program's a little bit unique in that, you know, we do 200 lung transplants a year, and our ICU tends to be full of lung transplant patients. So we put a more severe pause on our lung program just to try to free up some ICU capacity in anticipation of a big surge. So we're only doing very rapidly deteriorating lung patients.
Okay, thank you. And I guess the other thing I will say, because we don't have time to really go into it, but I will try to make sure that everybody that's on the call and in some of the materials has the link to the JAMA video, which I think is also very helpful in this regard. And with that, and in fact, it may, I don't know, they'll have to update me and see if that's actually on the resources that is actually on the link there, and the staff can probably provide that information. And with that, we'll go on to next steps. Stuart.